and welcome to the CAP Today webinar for Tuesday, June 29th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentations. Today's webinar is entitled, Show Me the Data, Multidisciplinary Treatment Planning in Early Stage Breast Cancer. And I want to acknowledge that this particular webinar is made possible by a special educational grant from Agendia. We're very grateful to them for their help and their support in bringing you this very important program. Our two speakers today will be giving the formal presentations, and I'll say more about each man in due course. Dr. William Audeh is Agendia's Chief Medical Officer and a very distinguished breast medical oncologist with a long track record of service. And Dr. David Hicks, of course, is a pathologist at the University of Rochester, who's no stranger to CAP Today webinars. But first, before I ask us to begin the formal presentations, I'd like to do just a little housekeeping with you, which I think may enhance your appreciation of today's program. First, we recommend that you refresh your browser. There's also live help available to you throughout today's webinar. You see an 800 number, 888-364-8804 in the lower right-hand corner of your screen. You can call that at any time. In addition, there is a Q&A box below the slides. We'll take away our meeting beginning sign there if we can. And in the Q&A box, of course, you can ask your questions and make comments at any time throughout today's webinar. But also, if you have a technical issue and you need to ask a question about sound or the website or whatever, you can type your question in there. And again, live help will be available to resolve your question. We plan to post the full audio and slides of this webinar in about a week. You can see it at captodayonline.com, and it will be nice to refresh and go over that again. Also bring some other colleagues in who couldn't be with us today. I want you to know you will see some follow-up email after today's webinar, including some from Agendia, so please know that that's quite legitimate when you see it. Finally, and as always, it's important for me to note that CAP Today does not endorse any product or service that may be mentioned in today's webinar. And also, any comments of mine are purely personal. They're not to be taken as official policy of the CAP Today or of the CAP. And now with that, let's turn to our program. And our first speaker is Dr. William Audeh. He trained at the University of Iowa and then moved to Stanford, where he trained in internal medicine and oncology. And like many Midwesterners, he's remained there and flourished in California. And he'll give us the first presentation. He is the Chief Medical Officer of Agendia. Dr. Audeh, please begin.
Well, thank you very much, Bob, and thank you, CAP Today, for the opportunity to speak to this august group. As you heard, and by way of disclosure, I am the Chief Medical Officer for Agendia, where I've been for the last 5 years. Prior to that time, nearly 30 years in active practice and clinical research in breast medical oncology at the Cedars-Sinai Medical Center in Los Angeles and UCLA. What I'd like to talk to you about today is the expanding utility of genomic information to supplement pathology information in managing women with early-stage breast cancer. To do that, I want to review with you the two assays that are provided by Agendia, which we think of as functional genomic profiling of breast cancer. There is the MammaPrint 70-gene assay, which predicts the potential for distant metastases in the first 5 years primarily, but as we will see, also provides information for later risk of recurrence. And the output is reported as either a low or high risk. The other assay we provide is the 80-gene BluePrint assay, which identifies signaling pathways which drive cancer growth. Importantly, these two assays are performed on formalin-fixed, paraffin-embedded tissue samples from either the surgical resection or the core needle biopsy. And I will point out that the majority of the samples we now receive are preoperative core needle biopsy samples. Together, these assays provide a comprehensive view of breast cancer. As you can see here, multiple subtypes within the luminal type, the HER2 type, and the basal type, including high-risk estrogen receptor positive basal type, which I will mention in a moment. Here I show you a variety of questions as well as information that is answered and provided by Agendia's assays as well as our research platform looking at whole transcriptome data. But to begin with, I will focus first on the primary question for which genomic assays have been used in breast cancer, and that is to determine who may safely avoid chemotherapy, both lymph node positive and node negative. MammaPrint actually began as the result of a research study in which researchers from the Netherlands Cancer Institute were asking which breast tumors can metastasize early, and can we use gene expression profiling to identify those tumors? The purpose of this, of course, was to distinguish tumors metastasizing early from those which did not, allowing better selection of patients who really needed chemotherapy. This landmark paper was published in 2002, and this led to the discovery of the 70 genes which predict the likelihood of distant metastasis. At the time of the initial report, the function of many of these genes was unknown, but over the ensuing years, we now know that all of them are involved in one or more of the 7 steps in the complex biological process of metastasis, from growth and proliferation to angiogenesis, all the way through to the final step, which is adaptation to a secondary site and growth to become a clinically evident metastasis. All 70 genes are involved in one or more of these pathways. Now, the clinical validation for the 70-gene MammaPrint assay came with the landmark MINDACT trial, in which approximately 7,000 patients were enrolled. The first results from this trial were published in the New England Journal, as you may know, in 2016, at which time 60% of the patients had at least 5 years of follow-up. In 2020 at ASCO, the 8.7-year follow-up was presented, and this was then followed earlier this year by the final publication with the long-term follow-up from the MINDACT trial. Now, this trial was intended to answer the question which patients really may safely avoid chemotherapy. And the way this was done was to look at patients who were clinically high risk with features that would cause me as a medical oncologist to want to give them chemotherapy, but genomically low risk according to the MammaPrint 70-gene assay. And what you see here are the data from the long-term follow-up, where the main endpoint was the 5-year distant metastasis-free survival, which in this group that was clinically high risk, MammaPrint low risk, and treated only with endocrine therapy, they had an excellent outcome of 95.1% distant metastasis-free survival, which was not significantly improved by the addition of chemotherapy. Another very important finding from the MINDACT trial, in fact, the first of its kind in a prospective randomized trial, was the ability of MammaPrint to identify patients with 1 to 3 positive nodes who could also safely avoid chemotherapy. Those data were first presented in 2016 with, as you can see, the chemotherapy group in red, no chemotherapy group in blue, and no significant difference between them at 5 years in distant metastasis-free survival. This, in fact, made MammaPrint the first genomic assay with prospective randomized data in this 1 to 3 positive node group, and led to MammaPrint being the only assay to be approved for use in node-positive patients by ASCO in 2017. Last year at ASCO, and now in the publication, of course, you see the long-term follow-up of the node-positive cohort, and the finding here is that even at 8 years, the difference is still negligible and quite durable. In other words, and I apologize for that, in other words, these are, again, the only prospective and randomized data with now 8 years of follow-up in the positive node cohort. And I will say these data came out many years before any other assay had prospective randomized data in the positive node group. Another important finding from MINDACT was an age effect of chemotherapy. Here you see that same group, distant metastasis-free survival in clinically high-risk, genomically low-risk patients, separated now by whether they were 50 years or younger or over 50 years. And the important finding was that although these patients were genomically low risk, if they were 50 years or younger, they did indeed show a benefit of chemotherapy, although that benefit did not start to appear until 4 years into their course. And by 8 years, the difference was approximately 5%. This is in contrast to the women on the right, for whom there was no benefit of chemotherapy, even though they had the same clinical pathologic features and the same low MammaPrint risk. So this raised the question as to whether estrogen receptor positive breast cancers in women 50 years and younger had some intrinsic biological difference that made them more chemosensitive. To provide some information to answer this question, Agendia and a number of colleagues participating in our so-called FLEX trial, which obtains whole transcriptome data, did a specific analysis of age as it affected the biology of breast cancer. This was presented just earlier this month at ASCO, in which we undertook whole transcriptome analysis of tumors that were hormone positive and HER2 negative from women 50 years and younger, and compared them to women over 50, not just with MammaPrint and BluePrint, but also in the entire transcriptome available to us through this trial. The findings are shown here. What you see on the left is a scatter diagram in which each dot represents the genomic profile of the patient and their entire transcriptome. Women under 50 in blue, over 50 in red, and you can see they do not separate. They cluster entirely together. In fact, we found no significant difference in gene expression based upon age. And this allowed us to draw the conclusion that there is really no apparent intrinsic difference in biology of hormone-positive breast cancers, even with MammaPrint low risk, that is attributable to age. And we believe that this supports the hypothesis that that benefit of chemotherapy that was seen in MINDACT, and I will point out in other large trials of the same type, is not due to a direct chemotherapy effect, but more likely due to secondary ovarian suppression by the chemotherapy. This leads us in the way we believe the MammaPrint data should be applied in making treatment decisions to this algorithm for shared decision-making for adjuvant therapy. Certainly, the data in post-menopausal women with low-risk MammaPrint identifies them as safely avoiding chemotherapy. For pre-menopausal women, where that small chemotherapy benefit was seen, most likely due to ovarian function suppression, we believe that this information should be integrated into shared decision-making in which both chemotherapy as well as ovarian function suppression can be discussed with younger women. Now, that was about making the chemotherapy decision, but the data I want to show you now involves the utility of MammaPrint in addressing endocrine therapy decision-making. For this, I want to point your attention to the ultra-low risk MammaPrint in hormone-positive breast cancers. We know that within the low-risk range, which runs as MammaPrint is reported from above 0 to +1, that there is within that low risk range an ultra low risk that is above 0.355. These data were published in JAMA Oncology in 2017. Now, the importance of these data came from the fact that although we understand, as I mentioned, that MammaPrint low risk indicates the lack of any likely chemotherapy benefit, it had also been observed that MammaPrint ultra low risk patients above 0.355 in the MammaPrint index had an excellent prognosis over at least 10 years. To validate this over the long term, it was necessary to go back to an old cohort, the Stockholm tamoxifen trial, in which over 650 postmenopausal women with tumors 3 centimeters and smaller and negative nodes were randomized back in the 1970s and 1980s to either no endocrine therapy after surgery or tamoxifen for some period of time, primarily 2 years, but some for 5 years. The benefit of this cohort is that they had not only the paraffin-embedded blocks, but also over 20 years of follow-up of these patients who were either treated only with surgery or, as you can see, with minimal endocrine therapy. We were able to extract the RNA from the blocks and perform MammaPrint on these patient samples, and we found approximately 19% fell into this ultra-low risk range. With 20 years of follow-up, the surprising findings was that there was a 97% breast cancer-specific survival out to 20 years if they had received any tamoxifen at all, even just 2 years, and that rate was 100% at 10 years. Furthermore, the group that did not receive any treatment, only surgery, if they were ultra-low risk by MammaPrint, they had a 94% breast cancer-specific survival at 20 years with no endocrine therapy whatsoever, nearly 100% at 10 years. Now, here's another graphic representation of those same data where you can see that the curves only begin to separate at about year 10. Also importantly from this study was to analyze the remainder of the low-risk patients who were not ultra-low. They actually had a very different outcome. You can see in the dark green the treated patients in the solid line and the untreated patients in the dotted line. You can see that unlike the ultra-low risk patients, they had a very significant benefit of endocrine therapy if they were low risk, but not ultra-low. Now, those data were the first to look at a prospective trial published in 2017. We now have these two additional trials that were presented in late 2020. The IKA trial on the left presented at ESMO, and the FOCUS trial on the right presented at San Antonio, both of which also identified the ultra-low risk group in red on the left, in green on the right. Although these trials had different endpoints of recurrence-free survival and distant recurrence rates, you can see that consistently the ultra-low risk group does better with long-term follow-up. And in these trials, 3 years or less of tamoxifen therapy. Finally, and most recently, we have data that was just presented at ASCO earlier this month from the original MINDACT trial that I mentioned earlier. Within the nearly 7,000 patients in MINDACT, we were able to also analyze separately those with an ultra-low risk MINDACT signature. What had been presented by Dr. Josephine Cardoso from the Netherlands Cancer Institute on behalf of the EORTC was the fact that 15% of the entire MINDACT cohort fell into this ultra-low risk range, about 1,000 patients. The majority of these women were post-menopausal and node negative. And again, even though in this case we had 8 years of follow-up, the ultra-low group did indeed do exceedingly well, consistent with the prior studies. Here you see the breast cancer-specific survival of the MammaPrint ultra-low risk patients, whether or not they were deemed to be clinically low risk or clinically high risk, with an 8-year breast cancer-specific survival of nearly 100%, very similar to what had been seen in the other trials. Furthermore, when one looked at how these patients were treated, there was, in fact, a group within MINDACT that deviated from the protocol and received no adjuvant systemic therapy whatsoever. That is the group in blue labeled no AST. At 8 years, their distant metastasis-free interval was 97.8%, little different from those that received any endocrine therapy at all. Again, showing the consistency of this ultra-low risk group. So we now report this in our MammaPrint reports because we do believe that postmenopausal node-negative women who have an ultra-low risk MammaPrint may be able, if they need to, they may be able to discontinue endocrine therapy before 5 years have been completed if they are experiencing severe toxicity. We do not advocate withholding endocrine therapy even from the ultra-low risk group, but as we all know, endocrine therapy carries considerable side effects, and for those women who want to stop early, it may be safe for them to do so if they're ultra-low. Now, the remaining low-risk group that is not ultra-low also became very significant with additional data presented at ASCO this year, specifically regarding the utility of extended endocrine therapy beyond the first 5 years. This was an analysis of the original NSABP B42 trial, in which extended aromatase inhibitor therapy was analyzed. And MammaPrint was used to determine whether that assay could identify which patients would actually benefit from extended endocrine therapy in years 5 to 10. If you remember the original B42 study, it enrolled women who had completed their first 5 years of anti-estrogen therapy and had had no evidence of recurrence. They were then stratified to receive either an additional 5 years of letrozole, so overall 10 years of endocrine therapy, or placebo, only a total of 5 years of endocrine therapy. The results of this trial, without any specific biomarkers or clinical features to identify which patients would benefit, did show overall a 3.3% disease-free survival benefit for the letrozole arm. But there were no clinical indicators to identify which patients would obtain that benefit. This was the reason that MammaPrint was applied to this cohort. The findings were presented at ASCO this year by Dr. Priya Rastogi from the NSABP, and I show you those here. It was the MammaPrint low-risk patients, not high-risk, who showed the benefit of extended letrozole therapy. And you can see the magnitude of the benefit here. For disease-free survival, MammaPrint low-risk patients who were treated with 10 years of letrozole had a 7.8% absolute benefit in disease-free survival with a significant p-value, as you can see. For breast cancer-free interval BCFI, again, it was the MammaPrint low-risk group, which had an absolute benefit of 7.0% with again, a significant p-value. Now, when one removes the ultra-low risk from this group, or at least separates them, you see an even more significant difference. Here you see the disease-free survival for the low-risk patients who are not ultra-low, LNUL. And the absolute benefit of disease-free survival improves now to 9.5%, and the BCFI improves to 7.9%. Again, showing that by using MammaPrint in this setting to determine who will benefit from extended letrozole therapy, the low-risk patients who are not ultra-low have the largest benefit significantly greater than what was seen in the overall group in the original B42 trial. What that does really, in the data that I've just shown you, is provide a large number of answers in using MammaPrint, not only for chemotherapy, but also endocrine therapy decision making. Of course, we understand from MINDACT that low-risk MammaPrint patients are unlikely to benefit from chemotherapy. And now we see from the Ultralow data that MammaPrint can be used in endocrine therapy planning for the first 5 years, and now for extended endocrine therapy as well. Now, I want to move on to additional genomic information that is provided by our assays to understand the diversity within the estrogen receptor population. And for that, I need to return to the other assay, BluePrint. BluePrint is, as I mentioned, a subtyping assay which was developed by Agendia using a supervised gene expression clustering analysis, beginning with standard pathology using immunohistochemistry and fluorescent in situ hybridization, as well as single gene mRNA expression, to then ask from the transcriptome which genes adequately and accurately identify luminal, HER2, and basal type tumors. The validation was first published a decade ago here, and what I show you here are the 80 genes in the BluePrint assay. The luminal signature in green, the basal signature in red, and the HER2 signature in yellow. Importantly, BluePrint compares favorably to the original intrinsic subtypes that had been originally reported. And in fact, there are some genes which overlap, as you can see here. There is also high concordance between BluePrint and intrinsic subtyping of 92%. The clinical validation of BluePrint came with the so-called NBRST trial. This was a trial enrolling over 1,000 patients who were going to receive neoadjuvant therapy based upon their classification by immunohistochemistry and fluorescent in situ hybridization. That determination, of course, had been made on the core biopsy prior to treatment, and the systemic neoadjuvant therapy was determined based on their IHC FISH. However, that same pre-op core biopsy sample was subjected to MammaPrint and BluePrint, and the outcomes were compared. What was found was that there was a 22% discordance between the classification by IHC and by genomic profiling. And this discordance also played a role in predicting which patients would achieve a pathologic complete response. The groups in which this discordance was primarily seen was in the HER2 positive cancers who were genomically more dominantly driven by luminal or basal biology. And as I will focus now, the estrogen positive cancers by IHC that were genomically basal with little or no estrogen signaling. Now, what I show you here are the pathologic complete response rates. On the left, by estrogen receptor positivity from IHC, the overall pathologic complete response to neoadjuvant chemotherapy was 10%. However, when one applies MammaPrint and BluePrint to further stratify these patients, what you see on the right are the PCR rates. Luminal A, 2%, luminal B, 6%, and importantly, the group that is genomically basal by BluePrint with a very different pathologic complete response rate of 34%. In this cohort, 13% of all the hormone-positive patients were found to be genomically basal with, as you can see, a very different rate of pathologic complete response and chemosensitivity compared to the luminal A and luminal B tumors. I will point out that with MammaPrint and BluePrint, we define luminal A as tumors that are low risk by MammaPrint and luminal in their BluePrint subtype. And we define luminal B as high risk by MammaPrint and luminal by BluePrint. The basal groups are nearly always high risk by MammaPrint, but by being basal through BluePrint, we are not detecting any hormonal signaling. When we limit our analysis to just hormone-positive patients that are MammaPrint high risk, the basal group makes up nearly 30%. Now, when I first saw these data, as most clinicians would, I suspected that these ER-positive basals were the hormone-positive patients with the very low estrogen receptor expression by IHC. But that, in fact, is not the case. What you see here is, again, a scatter plot with all of the IHC levels for these ER-positive basal breast cancers. And while they do tend to cluster at the lower range of IHC, you can see that the range goes all the way up to 99%. Progesterone receptor can also be positive, generally up to 50%. So these receptors don't definitively allow the identification of which patients are basal. And here you see a comparison in the PCR rates between IHC-defined triple negative in yellow and BluePrint-defined ER-positive basal in blue, where you can see that they are almost identical compared to luminal tumors by BluePrint. Now, besides pathologic complete response rates being very different, the outcomes are also different. What I'm showing you here are 5-year data that were presented at San Antonio this year, in which the patients from this NBRST study had outcomes determined by whether or not they had achieved a pathologic complete response. On the left, you see the probability of distant metastasis-free survival. And in green are those basal tumors by BluePrint that did achieve a PCR. So although this is an aggressive tumor, if they achieve a PCR, they have an excellent outcome. And conversely, if they do not achieve a PCR, just like with triple-negative breast cancers, these ER-positive basals have a very poor outcome, if they do not achieve a PCR. On the right, you see the comparison between the two high-risk MammaPrint hormone-positive populations. The luminal Bs in blue, PCR solid line, no PCR in the dotted line, and the ER-positive basals in red. Again, you see the very poor outcome of ER-positive basals if they don't achieve a PCR, behaving in every way like triple-negative breast cancers. So we believe that BluePrint is essential for identifying these high-risk estrogen receptor-positive breast cancers who are biologically and genomically in every way identical to triple-negative breast cancers, except for the fact that they express estrogen receptor protein, which appears to be non-functional. In my final comments, I want to share with you the research protocols with which Agendia is involved and collaborating. One is, of course, the I-SPY trial, in which we have observed that the highest level of MammaPrint risk appears to be associated with responsiveness to targeted therapies such as immunotherapy. I-SPY, as you may know, is a neoadjuvant therapy trial seeking biomarkers for prediction of response. And they have elected in their study design to use MammaPrint as a genomic screen for their hormone-positive patients. They will, in fact, only enroll high-risk MammaPrint patients when they are seeking pathologic complete response rates as their endpoint. Data that has been generated by I-SPY and presented here at a recent AACR meeting shows that as the MammaPrint index becomes higher in the high-risk range, which by MammaPrint is in the negative range, the likelihood of a PCR in the dark blue goes up, indicating that there is indeed an association between MammaPrint risk and chemosensitivity. The most important finding here is that This highest end of the MammaPrint high risk range, known as high 2 or MP2, has clinical meaning. That was displayed in one of the I-SPY trials that was recently published, and that is a trial in which, comparing to standard of care chemotherapy, the experimental arm used two targeted therapies, the immune checkpoint inhibitor durvalumab and the PARP inhibitor olaparib in combination with chemotherapy. In looking at rates of PCR in hormone-positive patients, what I'm showing you here are the data for the MammaPrint high-risk ER-positive patients that are in the lower end of the high-risk range, known as high 1, where the experimental arm did no better than the control arm in blue. On the right, you can see a separation of these curves where the experimental arm, the immunotherapy and PARP inhibitor, had a dramatically different rate of pathologic complete response when this was given to patients who were in the highest range of the MammaPrint risk, high 2. And we believe that this will become a helpful biomarker for identifying ER-positive patients who may be benefiting from immunotherapy. So as with the low-risk range in MammaPrint, we now have additional information in the high-risk range. We do believe that the high-risk MammaPrint does identify chemotherapy benefit. MINDACT was not designed to show the benefit of chemotherapy in MammaPrint high-risk patients, because the design and power of MINDACT was to show the importance of low-risk MammaPrint. But we have other studies in which there is a correlation between high-risk MammaPrint and increasing chemosensitivity. And now, as we split MammaPrint high-risk into high 1 and high 2, we also have these intriguing findings from I-SPY showing that these high 2 or ultra-high-risk MammaPrint patients are not only the most chemosensitive patients, but they also appear to have more sensitivity to immune checkpoint inhibitors such as pembrolizumab, as well as PARP inhibitors and possibly even carboplatin. That leaves, interestingly, as a subject for further and future research, the rest of the MammaPrint high-risk patients who are in that high 1 range. They need something more than chemotherapy and endocrine therapy, and we believe this may be the group that may most benefit from CDK4/6 inhibitors, subject to future research that Agendia is undertaking. In terms of research, and I will close with this, I have made mention of our so-called FLEX trial, in which we are utilizing whole transcriptome data to better understand and expand our knowledge of breast cancer. The FLEX study is a study that enrolls all early-stage breast cancer patients, and MammaPrint and BluePrint are performed on these patients. In the same run, in the same platform, with the same tissue sample, we are also able to obtain entire transcriptome data on each of these patients. And as part of this IRB-approved patient-consented trial, we also obtain multiple clinical data points and annotate the database. This database is then made available to our investigators around the country for sub-studies analyzing different subgroups within breast cancer. This now provides an extraordinarily rich, real-world experience whole transcriptome database with clinical annotation. Here you see a cartoon of the multiple sites around the country that are participating with us in this FLEX trial. Over 90 sites, 10 of which are NCI-designated cancer centers, hundreds of enrolling physicians, all of whom can submit requests for sub-studies to be performed on this pooled database, which now contains over 7,500 patients. This database, which began collecting patients in 2017, has yielded over 25 publications. As I mentioned, every breast cancer undergoes whole transcriptome analysis through this trial, in addition to MammaPrint and BluePrint. And I'll close by showing that at ASCO, FLEX yielded 5 different sub-studies providing data that were either in poster form or in an oral abstract form presented by Dr. Kent Hoskins, in which we look specifically at whole transcriptome differences in women of African American descent versus Caucasian descent with luminal breast cancers. Exciting data that is helping to better understand disparities in outcomes due to genomic and genetic ancestry. So what I've shown you are all of the information that's provided through Agendia's diagnostic assays, as well as the research that we are supporting in pursuit of expanding our knowledge in breast cancer. And now for the practical applications of all these data, I will turn the microphone over to my colleague, Dr. David Hicks.
Very good. Let me just jump in very quickly before Dr. Hicks begins his presentation to thank you, Dr. Audeh, that you gave us an enormous amount of very elegant science, 6 important studies to review. As I mentioned, we will be posting all the slides and all the audio online for your review. That was a very rich in science and very elegantly given a lecture for us. There's a lot there to think about, and I'm very, very impressed with that lecture, so thank you very much. And now, as promised, our final speaker, and before I ask him to begin, I'll remind you, you can make any comments or ask any questions you wish using the Q&A box below the slides, and we'll attend to them in our Q&A session very shortly. But our second speaker and final speaker today is Dr. David Hicks. He trained at the University of Pennsylvania, studying first internal medicine, and then, to the great delight of our specialty, entered the field of pathology, where he's become an extraordinarily distinguished figure. He's a professor at the University of Rochester Medical Center. He's the director of the IHC and ISH laboratory there, and he directs the breast subspecialty service, again at the University of Rochester Medical Center. He's been a stalwart in many CAP committees and helped to cap ASCO guidelines. It's a great pleasure to introduce him once again and ask him to begin. Dr. Hicks.
Thank you, Bob, and many thanks to Dr. Audeh and to KEP today for the opportunity to share with the audience some of our real-world experiences with performing genomic profiling of breast cancer cases on the patient's preoperative needle core biopsy. As everyone already knows, breast cancer is the leading cause of cancer death in women worldwide, and the second most common cause of cancer death in the U.S. after lung cancer. While the incidence has been increasing, there's been a decline in mortality from breast cancer over the last several years, due in large part to public education, screening, therapeutic advances, and probably most importantly, our better understanding of breast cancer biology. We've come to appreciate that what we call breast cancer consists of a heterogeneous groups of tumor types with varied morphology, tumor biology, and most importantly, response to therapy. This makes management challenging and calls for a personalized approach to treatment that is tailored to the individual patient. In making treatment decisions, the multidisciplinary team must weigh the risk of recurrence and the likelihood of response against the burden of various treatment regimens. This risk assessment takes into account a number of patient factors, tumor-related factors, including breast cancer biomarkers, and increasingly a look at the breast cancer biology through the use of genomic profiling of the patient's cancer. Molecular subtyping, as you heard in the previous lecture, has provided important insights into our understanding of tumor biology, the clinical course of disease, and response to therapies. These molecular subtypes correlate with morphology and immunohistochemical profiles, and pathologists have developed IHC surrogates for these molecular subtypes using histologic grade and cancer biomarkers. It's critically important to remember that the interpretation of molecular profiling of breast cancer must always be made in the morphologic and pathologic context for the patient's tumor. In breast cancer, RNA gene expression analysis has been shown to be the most informative molecular modality for breast cancer and offers additional additive new information beyond conventional pathologic tumor features. And there are a number of commercial assays available for evaluating breast cancer, which can be performed on formalin-fixed paraffin-embedded tissue samples. We began to be involved in the profiling of core needle biopsies with the onset of the COVID-19 pandemic. The pandemic has affected nearly every aspect of life here in the hospital, including the screening, diagnosis, treatment, and follow-up for the care of patients with breast cancers. The recommendations were made that healthcare systems delay elective care, and this included breast cancer surgery. In response to these recommendations, the Breast Cancer Consortium and the Society of Surgical Oncology released guidelines suggesting that in some cases the use of core biopsies for genomic testing could be very helpful in making decisions about surgical versus neoadjuvant treatments. In dealing with the pandemic in our breast center, we've struggled with the following questions. Will genomics via core biopsies impact triaging patients who are essential versus non-essential under this current and very difficult circumstances? And will early access to genomic test results lead to more efficient and effective breast cancer management decisions? Our standard workflow when evaluating core biopsies from newly diagnosed breast cancer patients would be to order ER, PR, HER2, and Ki-67 on the diagnostic needle core biopsy, and decisions on genomic profiling typically were made post-operatively with tissue being sent from the resection specimen. During the pandemic, we changed that workflow. We participated in the preoperative clinical impact study, and our workflow changed where we sent unstained slides at the time the breast cancer biomarkers were ordered off for genomic profiling in hopes that genomic profile results would be back in time for the patient's surgical consultation and treatment decisions. We sent, between April of 2020 and September, we sent over 200 specimens to Agendia for MammaPrint and BluePrint studies. 10 unstained slides were sent for genomic testing, and they were cut at the same time that the receptor testing was ordered. We wanted to evaluate, first of all, the success rate of testing using these core tissues. What was the average turnaround time for results? Would it be available at the time of the surgical consult? And then what was the reclassification rate? How often was the genomics discordant with our clinical morphology and immunohistochemical results? And then finally, and probably the most challenging, is how often did this result influence treatment planning? Our success rate was 95.3% of the specimens that were sent had sufficient material for genomic profiling. The turnaround time was quite quick. From biopsy to the time the results came back, on average was 10.02 days, and the turnaround time from the lab was around 5 days. Results were available for the treatment planning conference and the surgical consultation 100% of the time. And in terms of how often the results differed from our pathologic interpretation, the reclassification rate was around 32%. And in the next slide, I'd like to show you some of these reclassifications. We had one ER-positive breast cancer that came back with basal genomics. In our triple-negative breast cancers, 16% of them came back as a luminal type. For ER-negative, HER2-positive, 17% of those came back as basal. For our triple positives, we saw 17% came back as luminal B and 5% came back as luminal A. And for what we would consider clinical high risk, tumors that were T2 and above and lymph node positive, 39% of them came back as a luminal A subtype. And in our clinical low risk group, 62% came back as MammaPrint Ultralow. Let me show you a couple of cases of these reclassifications and how the genomics really sort of influenced our thinking about the case. The first one was a 74-year-old postmenopausal woman. She had no family history. She had an 8-millimeter mass on routine mammography, and a core needle biopsy was performed. We see here the morphology. It's an invasive carcinoma of an intermediate histologic grade. It has abundant eosinophilic cytoplasm and a suggestion of some apocrine features. The immunohistochemical panel came back ER negative, PR negative, and HER2 negative. So this was a triple negative breast cancer. And the response on the part of the clinicians would be aggressive and would elicit thoughts about neoadjuvant chemotherapy. When the genomics came back, this particular breast cancer came back with a luminal A molecular subtype in a MammaPrint low risk. And as you can see here from the report, neoadjuvant chemotherapy would be unlikely to have a good pathologic response. So a very different genomic profile compared to our pathology. This, of course, elicited an immediate call from the oncologist and said, what's going on? You said this was triple negative, and molecular said this was low risk and luminal subtype. I think there were some hints from the pathology. This did not look like a typical basal phenotype breast cancer. It was an intermediate histologic grade, and it had apocrine features. And so we performed an androgen receptor test, and what we saw was that all of the tumor cells were strongly positive for androgen receptor. And I think what this case represents is an example of a luminal androgen receptor subtype of breast cancer, an unusual subset of triple negative breast cancers that behave very differently from the typical triple negative. The next case is a 72-year-old postmenopausal woman with a palpable mass that was 3 centimeters. She did have a family history, and a core needle biopsy was performed. She had an invasive carcinoma, again of intermediate histologic grade. Her tumor showed fairly strong expression of estrogen receptor. The progesterone receptor was negative, HER2 was negative, and it had a fairly high Ki-67 proliferative index. So by immunohistochemical subtyping, I would consider this a luminal subtype of breast cancer, probably a luminal B. When her genomics came back, this came back as a basal type with a MammaPrint high risk. So this would be one of those ER-positive basal breast cancers that you heard about from Dr. Audeh. And unlike what we anticipated from the immunohistochemistry, the response to neoadjuvant chemotherapy in a patient with these genomics would be much closer to what one would expect from chemotherapy. So we found that this accelerated utility workflow, sending genomics early on at the time of breast cancer diagnosis in ordering the markers worked very well. The genomic information was available. And let me close by saying again that our understanding of breast cancer biology through the use of genomic profiling has been a real important step in optimizing risk stratification and treatment selections. And I think the pathologist has a role here in helping to interpret this information in the morphologic context for the patient's cancer. The genomic testing really did play an important role in our treatment planning during the pandemic and was something that was frequently discussed at tumor board, and I would receive calls from surgeons and medical oncologists. And in sort of reflecting on our experience, I think this approach has great potential for clinical utility beyond the pandemic, and our breast center right now is in active discussions about how we want to utilize this going forward. So with that, I want to thank everyone for their kind attention, and I'm going to turn it back to Bob.
Dr. Hicks, thank you very much. That's a very interesting talk that really shows how the pandemic has helped us understand how certain technologies can help us with workload, help us through difficult clinical times. A fascinating talk. We don't have a lot of time left, but there are two questions here, and I'd like to direct them to Dr. Audeh. Two among many questions, but I think we may have time only for the two. And Dr. Audeh, in the interest of time, I'm really going to combine two questions because I think they get at something that is very important for you to be able to speak to. First is, how do you respond to criticism that MammaPrint is not predictive of chemo benefit, although in some of your slides it's very clear that it can be? And then, of course, one that we might all expect, and I think we'd like to hear your response to. Dr. Audeh, how do MammaPrint and BluePrint tests compare with Oncotype DX? Dr. Audeh.
Well, thank you, Bob, and certainly thank you for those questions. They are always relevant. Let me start by answering the second question first. How do MammaPrint and BluePrint compare with Oncotype? Oncotype, as many people know, involves 16 informative genes, 4 of which are already provided through pathology: ER, PR, HER2, and Ki67. MammaPrint is 70 genes, which are really sampling many more pathways involved in the metastatic process, and BluePrint, conversely, an additional 80 genes, as I showed, is identifying signaling pathways as well as multiple downstream genes that are turned on and off in either the luminal or other pathways. So 150 genes which analyze a broad array of breast cancer biology, and as I showed you, answer multiple questions. I think the original development was different, but also I think the breadth of information that is provided by MammaPrint and BluePrint is also different. It does come down, however, to the initial and use of genomic assays, including Oncotype as well as MammaPrint, and that is this issue of whether or not MammaPrint is predictive of chemo benefit. Well, the reason that people may say that is based entirely on MINDACT, in which only clinically low-risk patients were randomized to receive chemotherapy or not, depending on being MammaPrint high risk. So the study was not designed or powered to detect the chemotherapy benefit in patients that are already defined clinically as being low risk. In fact, no assay has such significant data in that clinical low risk group. I did, as you mentioned, Bob, show quite a lot of data correlating MammaPrint high risk with chemosensitivity, not only from NBRST, but also I-SPY, and other trials where that was more the focus. But I'll also point out that the benefit of chemotherapy goes both ways. What you're talking about in predicting a positive benefit is positive predictive value. However, what MINDACT showed was the negative predictive value of MammaPrint, which was quite powerful. In other words, a low-risk MammaPrint predicts the absence of benefit of chemotherapy. And in fact, the major pathology biomarkers that we use in breast cancer, estrogen receptor and the HER2 receptor, are most valuable in their negative predictive value. Negative ER predicts lack of benefit to hormone therapy. Negative HER2 predicts lack of benefit to HER2 therapy. And low-risk MammaPrint predicts lack of benefit of chemotherapy. In fact, it is negative predictive value which is most clinically useful. And that is certainly what MINDACT showed with level 1A evidence.
Thank you. Dr. Audeh, thank you very much for that very, very good answer. It's a question I know that's out there. Dr. Hicks, I'm going to give you one brief moment to comment on the same question, because I'm sure you have been in some tumor boards and have been over some of the same ground with some of the same questions. So would you like to add something briefly to Dr. Audeh's comment?
Well, Bob, I agree with what Dr. Audeh said. They really measured different genes, and they were developed quite differently. And I also think that the negative predictive value, as Dr. Audeh has said, is probably much more useful clinically in telling us who does not benefit, as opposed to trying to predict benefit.
Very good. Dr. Hicks, thank you very much. I'll give you the last word with that answer, and now I'll begin to sum up. If you did not get your question answered, we'll be supplying all of them and all the comments to our sponsor at Agendia, who I'm sure will get your questions answered for you. They'll be there ready for you. And if not, you do let us know. We'll make sure everyone gets an answer to their question. But now I would like to wrap up, and of course I want to thank Dr. William Audeh and Dr. David Hicks. They've presented one of the better webinars we've done in a while on a very, very important topic. I was saying earlier, it's been a while since we looked at breast cancer, and it's very, very important that we stay up with this science, and we've seen a lot of it here. I know you'll want to go and review it. In addition to that, I really do sincerely want to thank Agendia for their educational support and their help in putting this on. It's been a fantastic program, a great webinar. We'll post it, as I said before, in about a week online. And finally, I want to thank all of you who've taken time in your busy schedule to join us today for this wonderful webinar. I hope you enjoyed it, and I hope you'll get a chance to share it with friends and colleagues soon. And with that, once again, thanks to Dr. William Audeh, Dr. David Hicks, thanks to Agendia, thanks to all of you. And with that, I'm going to bring today's webinar to a close.